Good morning. That was nice and loud and woke everybody up, I'm sure. Maybe spring is here. Let's hope. It sure looks like it outside. I'm very excited to introduce Dr. Floden today. She earned her MD degree from the University of Iowa, Carver College of Medicine, with a teaching distinction track. She then joined our residency program here and graduated with training in the health equity pathway. And she is now the Page Family Endowed Chief Resident. She has received numerous honors within the last few years, including membership in the Gold Humanism Honor Society, as well as several UW Internal Medicine Residency Awards, including the Sobey Matthew Award, the Sunday Award, the Chiefs Award, the Wellness Promotion Award, and the Dr. Perry Cox Award. How awesome. She has given both oral and poster presentations on a variety of topics, including advanced care planning, challenging conversations, medical errors, and cognitive bias. As we can see, she is really developing expertise in communication. We're especially excited that she'll be joining our Division of General Internal Medicine at Union Corners Clinic following her chief year. Dr. Floden is giving the first of the Chief Grand Rounds presentations this year, and we're looking forward to learning from you this morning. Welcome, Dr. Floden.
Thank you. Talk a little louder. Okay, great. Thank you so much for coming. Those of you who are here in person and those of you who are joining via Zoom, I'm so grateful to have this opportunity. It's not lost on me how wonderful it is that us chiefs get to talk at medicine grand rounds. How awesome is that? I'm excited to talk with you. I'm required to show this slide. I don't have any disclosures. I thought I would tell you a little bit more about myself on a personal level, so you know a little bit about me and why I find communication skills so much fun to learn about and to try to teach. I'm originally from Northern Iowa. I grew up in a town called Mason City and found my way to Madison. Just love the people here. I love the warm environment and the commitment to teaching here. And as I was trying to figure out how to be a resident and how to be a good doctor, I noticed that the people I really admired were really fantastic communicators. And that really inspired me because it seemed like when people were great communicators, their patients understood what was going on and what their options were. And their medical care is often so complicated, complicated even for me to figure out as someone training to be a doctor. And so that's why I find this work so invigorating and why I'm excited to talk with you about it today. It's also why I think I love teaching, because teaching, to be an effective teacher, means to be a great communicator, to connect with learners. And so that's part of the motivation for me doing a chief residency, and it's been a great learning experience. And so today, we'll take the next 45 minutes. I hope after this session, you'll be able to explain the role of communication in the practice of medicine, explore communication micro skills to really connect with patients. So we'll talk about what are some examples of those micro skills that can be used in your practice. How to incorporate this into your teaching as you work with and mentor medical students and residents and physicians throughout your practice. And then I thought this would be a great opportunity to talk with you about what our residency program is doing in terms of our curriculum scheduling. My role as a chief has been the curriculum scheduler. So my administrative responsibilities have been how do we organize the day, the week, the year for residents. And I think the new schedule that we've implemented this past year has provided a lot of great opportunities to improve the teaching we do for residents year after year. And how we'll get through those objectives, I'll talk about the why, like why does communication matter? Why is it important across lots of different specialties? And how can it be learned and improved upon over time? And then we'll talk about kind of how to teach it. What are some great skills to pass on to learners? And what are we doing here at the University of Wisconsin for our residents to begin teaching them about communication? And then we'll think about next steps. How can we grow? How can we learn and continue to improve the curriculum here at UW Madison? So starting with the why, I think it's helpful to tell stories to kind of get some of these points across. And so imagine that you're a first-year resident, maybe some of you are first-year residents, or And, it's August, so you've been in your rotation or been in residency for a few months, and it's your first night float rotation. You just pit in your stomach because you're nervous about night float, and you might be the only intern in the building. You're supported. Everyone says, "Oh, you're supported," which you are, but sometimes it doesn't feel that way when it's your first night rotation, and you get a call that a patient with a lung transplant is really struggling to breathe, and the BiPAP does not seem to be cutting it. They're working really hard, and you have to go assess them. You don't know them very well. You got a brief sign out on them, and think about all the cognitive gymnastics that are happening in that moment, right? You're assessing the patient's stability. You're thinking about, are they their own decision maker? Do they know what's happening to them? Who do I need to talk to care for them? Do I need to figure this out by myself? Call the fellow? These are really tough positions that require a lot of different types of skills, including communication skills. Similarly, new interns are part of their job is to deliver difficult news to updating families on how their loved ones are doing in the ICU, for example, very early on in their training law. And so to kind of bring it back to reality, I wanted to share with you some feedback we got from an intern after their first few months of being here at residency. As someone who started intern year in the ICU, I was responsible for calling and updating patient families. And I'll be the first to admit I sincerely struggled with this task. My medical school did not have similar training, and I had never heard of spikes until one of my rotations in October. We'll talk about spikes later, if you haven't heard of it. I was wondering if you had any thoughts on ways we could incorporate spikes training earlier in intern year, as I do not think we are protected from these difficult conversations, particularly in caring for our own patients in the ICU. This is something I feel strongly about because having these conversations are incredibly difficult and valuable for patients and their families. And I would love it if we can learn how to effectively and empathetically facilitate these early on. So I received this in an email and kind of at the beginning of my chief year. And it really made an impact on me because it's like people are asking for this training earlier. They think it would make a difference. It would make their job better. It would help them care for patients. And so thinking about the literature, what the literature tells us about the importance of communication skills, overall, there's a lot of evidence that specific communication tools and intentional teaching and communication are really helpful especially in high stakes situations, especially in residency when you're still learning how to be a doctor and you're in high stakes situations delivering difficult information in the middle of complex patient care. These conversations can be one of the hardest parts of our jobs and something that bothers us or weighs on us when they don't go well. Some further evidence that communication skills are helpful when various teams have incorporated intentional communication into their workflow, whether by partnering intentionally with palliative care in the ICU, by providing training to physicians and residents in communication. There's a lot of wonderful things that happen. We've seen evidence that there's improved medical team consensus when communication is really high quality. There's decreased hospital length of stay, increased patient and family satisfaction. And actually, when you look at the malpractice literature, which I don't have a ton of experience with, but there is some evidence that physicians who employ communication skills as simple as, asking patients how they're doing emotionally with the news they're getting, or summarizing the information they're passing on in a clinic visit. Those simple interventions seem to be associated with fewer malpractice claims compared to physicians who don't utilize those strategies. So I think there's a lot of compelling evidence that not only does communication skills helps give our residents some peace of mind, so they have something to fall back on when they're working, in high stakes situations. It also, there's evidence that patient care benefits from it. I think now, let's ask ourselves, can we teach these skills? Or are some people really great communicators by way of their personality or their interests? And it turns out that communication skills can certainly be taught. So similar to, procedural skills can be taught. They can be broken down into simpler pieces that can then be used and built upon for the future. And so in looking at the literature, this pretty recent review from 2022 is really helpful in giving a nice summary of different strategies that have been used to teach communication skills and kind of giving us advice about how to incorporate those models into our own curriculum. And so this paper looked at 52,000 total papers and narrowed it down to 150 articles. And they looked at 4 domains of communication curriculum, primarily within medical schools. How the curriculum was designed, how learners were assessed, and what were barriers and enablers of really teaching this effectively. And throughout the article, they kind of use this framework. It's called Miller's Pyramid, which is used mainly in clinical teaching to kind of inform how do we best pass on knowledge and skills to clinical learners. And so the idea is you teach someone knowledge, and that's the very base of the pyramid. But a lot of times in medicine, we're doing complex things like communicating with people, performing procedures, coming up with a differential diagnosis, and then having that inform how we take care of somebody with treatment. And so at the base, there's knowledge, and then there's what do you do with that knowledge? Can the learner incorporate it into, doing something with it, whether through discussion or talking with a simulated patient. And then at the very, very top is, does that knowledge get transmitted to real life clinical practice? Which is often, I think, where we maybe miss out a little bit on assessing learners is, are they doing the things that we're trying to teach them when they're in clinic or on the wards? And so this paper really does a nice job of applying that to communication skills. So kind of at the base of the pyramid, curriculum can have didactic sessions. Here's how communication skills can be used. Here's some different micro skills you can try. And then in the middle of the pyramid, small group discussions, working with simulated patients. And then at the top is providing feedback to learners, watching them, observing them out in the wild, out in the hospital, talking with patients and providing amazing patient care. And so communication is very, very broad, very broad term. And so I have this picture of an umbrella to remind us there's a lot of different skills and applications for communication under that big umbrella. So some basic things that involve communication are taking a history, learning from a patient's symptoms and having them describe what's going on, kind of being very clear, using clear language, understanding the patient's perspective, and then kind of acknowledging emotions. We think of those as more intern level skills, things that hopefully you can build upon over time. And then thinking about more advanced skills, it requires some skill integration and kind of more back and forth between the like assessing the patient and providing information. So disclosing medical errors, breaking bad news, and thinking about how to communicate really well with vulnerable populations, such as people who have experienced sexual trauma or people who have inadequate access to resources. And as you can imagine, there's interplay between these two different sides of the advanced and core communication skills. It's really important to assess people's emotions as you're taking a sexual history from them, if they've been through something, they've experienced trauma, for example.
It is not on. I think I just turned it on now. I talk loud enough that maybe I was able to compensate a little bit. Great. Okay. In terms of barriers to teaching this, what makes it hard to do this well, to teach people how to communicate? We don't always know what people have had in terms of their medical school training. People arrive with different sets of skills, as that quote that I showed at the beginning of the talk. that person hadn't happened to learn much about this during medical school. Some people have heard a lot about these skills, and so they kind of, their eyes roll into the back of their head when you're trying to teach them about it, in a teaching workshop. And really, it's been within the past, I would say 15 to 30 years, somewhere in there, that medical schools and residencies have began to incorporate this teaching more intentionally. So, you need to teach the content, but you need people to teach it. And so if our teachers haven't had exposure to these ideas more formally, it can be challenging to recruit folks to teach it. There's a lot of people who are passionate about this content, but it's important to recognize that they might not have had formal training in these areas. As you can imagine, teaching something that requires experiential learning, such as simulation or observing people out on the wards, requires resources, having space, simulation space, paying actors, having people who you pay to coordinate the course itself if there's a lot of moving parts, as well as people to go out and evaluate learners on the wards. That all requires lots of people and time and facilities and resources. And then I think one thing that I've thought about a lot within my role as a chief resident is if there's not opportunity for ongoing repetition and practice and really meaningful feedback, these skills just go away. So there has to be a curriculum that's designed to repeatedly reinforce these ideas. In terms of successful strategies, it's sort of the mirror image of that. So building in a lot of opportunities for practice, having a learning environment that promotes trying new things and being willing to make mistakes in front of your colleagues, seeing how your colleagues respond to difficult situations when communicating. And then this idea of a spiraled curriculum, meaning you incorporate basic foundational principles. And then as learners advance and become more skilled, you revisit those foundational skills and then you layer on more complex ideas. And we'll talk about how our new schedule here at UW-Madison provides really awesome opportunities for making that happen. So, okay, we've talked about why communication matters, why I think it's so awesome, why lots of other people think it's important for patient care and for resident well-being. And we've talked about how can people learn these skills? How can we design curriculum that really takes advantage of different learning opportunities within communication? So next we'll talk about more specific communication micro skills that we've actually begun teaching our residents here, and then think about specific teaching interventions here at UW. So this is stuff that's very near and dear to my heart because it's what I've worked on over the past year in my current position. So these lovely people, Geraldine Palmer, Dr. Sarah Johnson, Dr. Jeremy Smith, and Dr. Andy Coyle, were all involved in designing a communication workshop for first-year residents. I see a few first-year residents here, so shout out to you for being in our first class. We called it Challenging Conversations 101, and it was a 2-hour workshop designed to give interns some practice at sharing bad news with patients, something that it sounds like they're having to do out in the world. So why don't we give them tools to do so? And so the goals were to standardize how we teach communication skills to folks rather than sort of just hoping that along the way they'll encounter wonderful mentors who might pass it on, on the wards or in clinic. And then with the second goal being, let's kind of look at these skills more deeply and provide opportunities to practice them earlier, rather than thinking, oh, this is more senior level content. They'll build on that. They just need to figure out residency at the beginning. And it's true, there's a lot that interns need to figure out in their first year. It's a really steep learning curve. But based on the feedback we received from interns, and based on all the evidence in the literature that teaching this earlier is impactful, we wanted to start in the fall of the intern year so they could use these skills as interns and then build on them throughout. And so the structure of the workshop itself consisted of a didactic session, like what are these micro skills? And then we recruited and trained a standardized patient who primarily worked with the palliative care fellowship. So the palliative care faculty, Dr. Johnson, was really instrumental in helping us do this. And we invited them to the workshop, and the leader of the workshop would demonstrate a clinical encounter with the simulated patient, delivering difficult news to them. And then we would pause and have time for the learners, about 8 to 10 of them in the room, to ask questions, to maybe make note of what was effective or what was confusing about the conversation between the faculty and the simulated patient. So they could see those skills being used and think about, how would I say that? How would, how can I take this forward with me? And then at the end, we had another difficult situation that the interns worked through in pairs. I think the situation was a patient's decompensating, you're on cross cover, you need to call their spouse to let them know what's going on. So kind of practicing those skills. And in terms of the types of skills that we were passing on teaching during this session, some really foundational things that are helpful for difficult conversations with patients. So I think it's easy to forget in medicine that we're dealing with information and trying to make diagnoses and trying to get through our day. But we often don't think about how challenging those scenarios can be for our patients and how they bring up a lot of emotions. And that if we don't acknowledge that elephant in the room, our patients probably won't hear what we're trying to tell them. So a big part of this workshop was thinking about how can we notice those emotions, acknowledge them with patients so that we can actually connect with them and kind of reach the goals that we have together. When delivering difficult news, it's really important to provide a summary, like this is what I hope this patient takes away from this conversation. Because it turns out if you don't go into a conversation with a goal like that, especially with really high stakes, like you have cancer, oftentimes things get lost in translation. So having a clear headline, sort of like a newspaper article, to deliver that news and leave the patient with a clear idea of the next steps. The cognitive trap is something that was a big unlock for me in the last year. Because as doctors, we like to focus on the facts a lot of times. And so when patients ask us questions, if it seems like folks are really focusing in on the teeny little details, like a family member asking, what was my loved one in the ICU? How much urine did they make today? What was their heart rate? What were their vent settings? Oftentimes we're really willing to focus on those questions when really the big picture is that the patient's really, really sick, and that's scary. So sometimes when people are asking questions or focusing on the facts, what they're really doing is maybe moving away from their emotional response to the situation. And so acknowledging that is really helpful, kind of taking that big picture view of what is it like for this person going through this challenging time in their life. Intentional pauses and silence can be used as a communication strategy. Several of the other grand round speakers have talked about how us doctors are really, we tend to interrupt people. I think the literature suggests like between 15 and 20 seconds is the average amount of time in those studies that physicians waited before interrupting a patient. And there's also literature to suggest that if you just let people talk, the most they'll talk is about 90 seconds on average. Because that's the fear, right? If you're in a clinic visit and you're like, oh God, I gotta wrap this up. I have another patient to see. So if I just let this person talk, it's gonna get away from me and I'm not gonna accomplish what I need to accomplish. It turns out oftentimes, there's always exceptions, but oftentimes if we just pause, people will get a chance to say what they need to say, then they feel heard. I think pauses are even more impactful when you're giving someone new information that's going to change their life. It gives them, it's kind of honoring that space, honoring the patient and saying, I'm telling you this really hard thing, and I'm going to let you sit with it. Because how else are you going to hear the rest of what I have to say if you don't give them that time? So it feels cheesy, but a lot of patients say that it was nice to have time to breathe and think before I start thinking about, how to deal with this information. And then I wish statements are another great tool to use when you're giving someone information or reaching a point in their care where it's unclear, where there's lack of clarity and you're not sure what the best treatment will be, or you're not sure what's going on, why they're so sick, and a patient's experiencing frustration, or you're getting a sense of denial. So an example of this would be, a really sick patient in the ICU who's in liver failure, and they're not a candidate for a transplant because they're so sick. I had a patient's spouse on the phone with me say, I can't believe that he's not a candidate for a liver transplant. Like, why? I can't believe this. And we had already talked about it. We had talked about why. And so rather than kind of falling into the cognitive trap of, well, here's all the reasons why your husband isn't able to receive a liver transplant, I just said, I really wish that he could. It puts you on the side of the patient. Like, I stand with you. And if I could offer that, if it were safe, I would, but I can't. I really wish that I could. And the goal of all these micro skills is not like to turn residents and doctors into like communication robots, like activate, I wish this must be really hard. That is certainly not the goal. But if these things don't come naturally, if we don't remind each other of how to have something to fall back on when you're struggling, when you're delivering difficult news to someone especially, can be really powerful and can kind of decrease the cognitive burden and the emotional burden of the provider and help patients feel more respected and heard. And then to kind of finish examples of spikes. Yeah, I love this picture. I think it's so cute. Spikes is it's kind of a micro skill set. It's like a toolbox because there's a lot of stuff happening within spikes. So the acronym SPIKES is used for, I am going to have a hard conversation with somebody or a family meeting. What do I need to do to kind of set myself up for success, for having this go well? So setting the scene, making sure you have a space to have the conversation, getting a sense of where the patient's coming from, what do they understand? What do they understand about the cancer diagnosis or the hospital stay? Always asking, like, is it okay if I talk about some really difficult things with you? Is a really kind way to remind the patient that you're there for them, and they have a say in the matter. Sharing the information. What's the headline? What am I trying to relay in an intentional way? Acknowledging their emotions and standing with them with empathic statements, and then clearly summarizing the conversation. So spikes is that's what that intern was talking about when they're like, I had never seen spikes before. And I really wish I would have had spikes when I was calling this patient's loved one in the ICU, and it kind of devolved. I think our program director, Andy, calls those the surprise palliative care conversations. Like the intern's just trying to update the family, and it turns into, oh my gosh, is he going to get better? And you're like, oh boy, wish I had spikes when that happened the first time. And so these are just some examples. And again, we don't want communication robots. We just want people who have some skills to fall back on to care for their patients. In terms of how the workshop went when we taught it for the first time this year, we had 24 of 34 learners complete the survey. Full disclosure, I think the group of 10 that we missed, the last cohort, I had COVID. And so we didn't get them the surveys that day, but you do the best you can, right? 22 of the 24 people who completed the survey rated their abilities in communication skills as confident. And the majority, 23 out of 24, felt the session would change the way they communicated with patients moving forward. 23 of the 24 respondents felt the session should be continued for future years. So I took that as a win. I think, a lot of things in training, you're not really glad when you're doing it, but you're glad having done it. So the fact that this number of people said, I'm glad I did it. And I think other people should have to do it too in future intern classes was that's heartening. Sometimes you hope for mediocrity in these, in these feedback in these evaluations. We did the theme of how can this be better? The theme of those responses was make it more experiential, make it more interactive. So examples of the free text feedback, if the session is continued, suggestion to make it 100% interactive. The more practice scenarios, the better. More exercises to practice situations. So I think that's a great example of that Miller's pyramid. Like, what's the most effective way to teach these skills is thinking about mirroring clinical practice, like mirroring the situations that people are going to encounter so they can practice different ways of responding, thinking about different ways they'll be challenged, because that's what they're able to translate when they go on to be physicians in the world. In terms of, okay, how are we trying to grow this curriculum? How are we trying to make it better? We've had a lot of great opportunities to share this work and continue to improve it. So thinking at the beginning of the timeline, this fall, we piloted the workshop for the first time with the current intern class here in Madison. And then in September, Dr. Mariah Quinn and Dr. Amy Zielinski were really, really kind and invited me essentially to present some of their work with them at a communication conference in Scotland. And so we presented that work, which was related to empathy. And while I was there, I got to talk with people, from different countries, different medical schools and residencies, like, how are you teaching people how to do this? And that was really inspiring because, I got to talk to people who were teaching surgeons how to navigate conflict resolution in the operating room. Like they had this simulation center where they have, very realistic surgery simulations, and they're arguing with, with a co-resident or that sort of thing. So that was a great way to think about, okay, we can really beef our own curriculum up. We can continue to make it better. And then in March just a couple months ago, Geraldine Palmer, a current senior resident here, submitted an education innovation grant to improve the communication workshop, with the goal being respond to the learner feedback, make it more experiential, have more funding to recruit simulated patients, pay simulated patients, and kind of allow the interns more opportunities for practice. And then in April, Dr. Quinn and Dr. Zielinski and I went to the University of Iowa and talked with their family medicine and internal medicine departments. We were presenting some work to their faculty development meeting. And while we were there, we talked to them about their X+Y curriculum, which is similar to ours. I'll talk more about that in the next section of my talk, but we got to hear how they teach these skills, which was great to think about how we can grow. And then in May, I'll be going to the SGIM conference in Colorado, and we'll present a poster on this work and get to talk with people who are doing cool things at their own institutions. So we've talked about the micro skills and how we're kind of trying to improve our own curriculum here. It's been so much fun to work on this, and I'm excited to see where it goes with, with future iterations. Now let's talk about X+Y. I know a lot of the people in this room are residents or chiefs or faculty who work closely with residents, but I thought in getting to meet faculty, not everyone is as familiar with X+Y. It's kind of complicated, and I didn't really understand it until I was forced to schedule people in it. So let's talk about it, because I think it's been a really great change to our residency program. So in the images there, you'll see our wonderful administrative staff, Jackie, Vani, Abby, and Natalie, and Andy, our program director, and my co-chiefs, Gabby, Nadia, and John, and just like the most awesome people ever. And so these are really the heart and soul of how did the X+Y get scheduled? How do we make this transition? Okay, what is X+Y? Instead of continuity clinic occurring a half day a week, whether you're on wards or ICU, so kind of the integration of those experiences, in X+Y clinic and inpatient rotations are separated. into X or inpatient blocks and Y or outpatient blocks. And this allows for kind of a regular pattern, if you will, of inpatient, elective, and outpatient experiences. In this, that's why you can see this regular pattern of green, blue, orange, or green, red, orange, green, red, orange. And to accomplish this, oftentimes residents or learners are broken up into groups where they rotate through that pattern at regular intervals together. So we often call those cohorts. So in this image, you can see that the top 7 interns are all in the same class. So they all have Z block together, inpatient blocks together, and so on. And then learners 8 through 14 are in a cohort where they start on an inpatient rotation rather than starting on outpatient. And if this all still looks like alphabet soup, I don't blame you, because it did to me. Even when I was trying to start making the schedule, I was like, oh boy, I really got to figure this out. And so Andy and the other chiefs were just so fantastic at making these changes. Andy has experience both from a curricular side, curriculum development and literature perspective on X+Y, as well as making it happen. He had experience from his prior institution in making the transition from a more traditional schedule to the X+Y schedule. And so I think it's helpful to just think about what's one person gonna be up to with this new model. So in this example, someone starts on outpatient, and these are all in 2-week blocks. So 2 weeks of outpatient, followed by 6 weeks of inpatient, back to outpatient, some consults, back to inpatient. So the outpatient learning happens at regular 8-week intervals, at least in our rendition of it. There's variations on the theme. There's different ways you can, have different lengths of rotations. Our program chose to go with 8-week intervals for our outpatient rotations. And why would you go through all this transition? Why is this helpful? There is a fair amount of literature on that subject. And primarily, I would say a lot of the driving force of this new scheduling is improving resident experience. Residency is incredibly challenging. This model really allows for better predictability. And one thing that really negatively impacts resident well-being is feeling like their schedule, like they have no control over anything. I'm pulled on this rotation, now I have to go to inpatient. I submitted my request, but there's certain demands that have to be met in terms of patient care. Having a schedule where you'll be returning to a regular pattern is really helpful, because then you can plan other things in your life around that. You can plan, I know I'll be on outpatient every 8 weeks. I can try to get to my dentist appointment or, see my family in those regular intervals. Other potential other benefits of this, when you can be in clinic all day for 2 weeks, you can feel more integrated into the team, as opposed to feeling like you're letting down your inpatient team in order to get to clinic on time. Having more kind of experiential time in the ambulatory clinics at those regular intervals. And really, from my selfish perspective as the curriculum admin lady this past year, there's more opportunities for protected learning. And so during those clinic blocks, if you wanted, you could build in half-day or full-day learning sessions, as opposed to scheduling a learning session and hoping that the inpatient teams can work out passing pagers or, getting away from the wards for a brief amount of time to go to a workshop, and then they're exhausted and trying to learn while they're thinking about their patients. On those regular intervals, you can say, today's going to be a learning day. And that's what we did here at Madison. So Fridays are our didactic day. No patient care responsibilities, aside from maybe answering in-basket messages and kind of taking care of clinical work, because Friday is a very busy day for outpatient medicine. So we have some time carved out for that on Fridays, but otherwise it's learning workshops or didactic sessions. No system is perfect. So residency is still hard. There's no denying that. And so some drawbacks of the system are outpatient continuity. I think these are challenges that we'll continue to to have to address as the schedule evolves. Rather than, now residents are not in clinic every single week. They're not leaving their inpatient rotation to go to clinic every Wednesday, for example. And so in between that time, it can be challenging to schedule, like for the schedulers to know how to schedule patients. Do I schedule this, this follow-up appointment with another resident because they wanted it to be in 6 weeks? Or do I wait another 2 weeks so that, Dr. Floden can see them when she's back on outpatient block? That can certainly be challenging. When you block out all those times, all those 8-week intervals for clinic, that can take away from time where residents are on electives. And since we have residents doing tons of awesome things and applying to fellowship in lots of different fields, that's a drawback that's worth noting. And finally, there is less flexibility in terms of coverage. If residents need to trade shifts or people are sick, because people are now divided up into those 4 cohorts, you have less flexibility in pulling one person to cover somewhere else. You kind of have to stay within 1 or 2 cohorts when making those coverage arrangements. So certainly not perfect, but I would say for the purposes of this talk, especially for like learning, X+Y is a game changer. So how do we teach within this model? A little more detail. We chose to do noon curriculum for the folks on inpatient and consults. And so that is the typical morning report, senior report, that all happens over the noon hour. That content is given one time. So whoever shows up that day, they get to learn that material. It's usually not recorded. And so it's a one and done. And for the outpatient curriculum though, this builds in that time for spiraled curriculum of learning and then building in the future because you have those regular 8-week intervals to take advantage of. So if content is delivered on a learning day, every single resident gets it, unless they're on vacation. We definitely want them to enjoy their vacation. And so those sessions can be long form, where they're a workshop, like our communication workshop, or they're shorter form. We invite a subspecialist to talk about an important topic, usually more relevant to outpatient medicine because it's happening on the outpatient block. And again, I think this reinforces, that review article I talked about, kind of the spiral learning and the building from basic knowledge and layering to more experiential learning and more advanced skill integration. This schedule is so helpful because it builds in a framework to layer curriculum on, rather than having to pull people from all different parts of the hospital. They aren't on cohorts. We don't know when they'll be back on a lighter rotation in a regular pattern in the way that X+Y allows. So I think that there are a lot of opportunities for us to utilize X+Y. And to think about what we've done in the communication skills teaching space this past year, we have a lot of curriculum. I think we should be really proud of what we're offering people. So the interns learn these skills through the workshop I talked about, motivational interviewing workshop, training on recognizing and addressing microaggressions, thinking about empathy and empathic skill development, as well as beginning to think about medical errors and how to talk about them. And then in the PGY 2 and 3 curriculum, we have a curriculum for 1s and a curriculum for 2s and 3s. So those folks are together. A lot of kind of similar courses with more advanced content. And to kind of summarize where we can continue to grow, because this is only in our first year of the X+Y curriculum. Definitely not masters, but thinking about how can we layer on more skill development. I think that we could do a better job of interprofessional conflict resolution. I think we focus a lot on patient care. How do we take care of patients in challenging situations? But I think sometimes the most challenging parts of our jobs are when we're not getting along with our colleagues, or one colleague sees a problem this way and I see it that way. How do we meet in the middle? Especially when there's a power dynamic. I think developing maybe a senior curriculum for interprofessional conflict resolution could be really helpful. Better interdisciplinary collaboration and communication. We have a chief resident, Carolyn Berkey, who's really interested in this work and is planning to develop curriculum in that space for next year. Thinking a little bit more intentionally about end-of-life goals of care and what residents should be learning in that area. It's certainly something that requires additional training and practice, but maybe including that earlier, similar to how we're trying to layer in skills earlier for interns to keep building on. And ways that we can accomplish this, I think we need to think big in terms of recruiting more people. So this year we were so focused on getting the curriculum organized and thinking about what the content would be, that we kept it fairly insular in terms of Andy, our program director, taught a lot of that material, and then the chief residents taught a lot of it. I think we can really utilize all the fantastic teachers and faculty here, as well as the fellows. There's a teaching focused fellowship program called the FAME program that I just learned about. And it's like, oh, that'd be a great way to recruit more teachers to kind of, bring in more ideas. And the residents love guest faculty. They get sick of us, sometimes. So I think it's great to involve more people. And then of course, more simulation and experiential learning opportunities. Whew, okay, well, we're almost done. So we explored learning in X+Y. Hopefully it doesn't look entirely like alphabet soup now that we talked about it a little bit. And we thought about how we can use X+Y to continue growing the way we teach residents in the future. Hopefully now we've accomplished our learning objectives and you can smash your CME questions if you choose to do those. And I just want to say thank you to the wonderful people who are, passionate about this work and who have mentored me. Thank you, Geraldine. Thank you, Dr. Smith, Dr. Coyle, Dr. Johnson, for all the work you did on the communication workshop. It was so much fun working on that with you. My main outpatient mentors in my residency were Dr. Schnell and Dr. Voss in the middle there, and they are just the epitome of physicians I want to be like. So really appreciate them. And then thank you, Mariah and Dr. Zielinski and Dr. Quinn for including me on your work. It's been so much fun working with you. Dr. Rosenbaum is faculty at Iowa, and she has been a great mentor for kind of thinking about how to think bigger and continue to improve our curriculum on communication. She's an expert in teaching communication, and she kind of reviewed our workshop and helped us think about how we can make it more aimed at improving clinical skills rather than just kind of what are we teaching interns. It's like, okay, what are we teaching them that they'll take with them and incorporate into the world? And then thanks to my wonderful husband, Patrick, for coming to Madison with me and for being the most wonderful supporter. These are our awesome residents who I've had the pleasure of working with for the past year. I think, they've either had to experience a brand new schedule, they were pioneers in living through this schedule for the first time. And then the senior residents, especially, were residents and in training in a really difficult time during COVID and had to deal with things that they didn't necessarily sign up for. So it's been such a privilege to work with them and be a part of their training. It's such like a formative part of their careers. So grateful for that. And then to end, thank you, John, Gabby, and Nadia. You are strong and smart in ways I am not, and it's been so much fun to work with you. I'm really sad that we won't be working together every day, but I'm so excited for what you do in fellowship, and we're really lucky that they're all staying here at UW. And that's what I got.
What a wonderful presentation. Thanks so much. I would love to be an intern in this program. I wish I could. Kinda. I have one question I want to start. We'll have audience questions and perhaps online questions, but in thinking about Miller's pyramid, at the very top is the implementation and the use of. So I'm curious about what parts of the 5 micro skills you think are most difficult for interns to implement, and whether the new grant will look at ways to help interns implement it in their practice with patients.
Yeah, I think I guess you spoke to the mic, so I don't have to repeat your question. Yes. So I got that for the Zoom crowd. in hearing from the interns during the workshop, like you can sometimes see people wrestling with ideas, or like they almost look like they don't quite buy it, you know? And that was the cognitive trap skill, I would say, is the most challenging, because you want to, if someone asks you a question, like a factual question, you want to answer it. You don't want to seem like you're evading them. Why isn't my husband getting a transplant? You're like, well, okay, we'll walk through this again. Maybe they don't remember. And so I think that is a challenging skill, because it requires assessing like where the patient is emotionally, or the loved one is emotionally, and making them feel heard, but also taking that additional step of, this must be really hard, or you seem like you're frustrated. And I really, we've talked about this, and I'm sure it's really difficult to accept that information. I think that's one of the more challenging skills. And in terms of how the grant would address that, I think the workshop that we implemented for the first time, there was a demo with a simulated patient, but the interns didn't get to directly work with them. And so the grant would allow funding to have more simulated patients, because that's more time and money that you're paying for. So it would allow them to practice that skill. And then I think the next step would be, how do you evaluate people out in the world and standardize that? Because right now we have there's, I think, evaluation fatigue, right? Of faculty trying to evaluate people in clinic and the wards, but how could we maybe incorporate that piece to see if people are using those skills, or if they're not? If they get the workshop and then choose to not utilize parts of it.
Thank you. Ooh, that's very loud. I'm bringing the microphone up here.
Hi, Sarah. Thank you for the amazing talk. I heard you talking about like implementing it in the real world. Have you thought about, after giving the curriculum as a PGY1, perhaps if PGY2s consent to the study where you get a random patient in clinic and see how pragmatic those skills are in clinic or in an inpatient setting?
Yeah, so the question, I guess you spoke into the mic, so I don't have to repeat your question. I always forget to do that, so I'm trying to remember. That's a great point, Ahmed. I would say there are institutions where, especially in clinic, there are patients who are going into the clinic visit to assess communication skills. And that, there's some ethical considerations there, because they're taking up a slot that would otherwise be filled by a patient with a need. But people are doing it, and it's a really effective way to try to assess skill retention over time. And that's not to say that residents aren't in the real world now. Like, they're very clearly taking care of patients all the time. Like, there's a bunch of people doing that, on wards right as we speak in this room. So yes, people are doing that. I think it would require a lot of funds to train those folks, and then to implement, you have to get buy-in from clinics, for example, to agree to that. I think other institutions that have been successful have faculty that they recruit who intentionally go on wards or into clinic to observe, to see if the skills are being utilized. And I think challenges with that are, how can we optimize the situations where they're going to evaluate? Like, you might just be having a routine conversation where you're not delivering difficult news and maybe about to use those skills. But those are some ideas I have, I guess, thinking about how patients or actors could kind of sneak in to evaluate learners that way. And then having a system where faculty go out, or senior residents go out and evaluate folks, and seeing how they're using those skills on the wards.
Thank you. There's several really positive comments online. Dr. Bartles, wonderful project. Dr. Siraj, great. Now I understand the X+Y curriculum. Dr. Barzi asked a question: how can we influence this teaching at a national level, particularly in the ACGME milestones, and help to get this implemented and moved to the next level?
Dr. Barzi is so amazing. I'm sure he has great ideas, probably ideas better than I do, in terms of how do we incorporate this into standard milestones that folks are expected to reach. And I guess I don't have a great answer to that question. I think there has been gradual expectations where now we should be teaching people this. Medical schools are incorporating it more and more, and residencies are starting to as well. I think it seems like the way to do it is to think about this impacts patient care. It should be a part of resident curriculum. So kind of leveraging that, I would say, to advocate to these national governing bodies to make that a part of the standard residency curriculum or milestones that residents are expected to reach. And if he knows how to do that, I would love for him to teach me.
Absolutely. Natalie Widener, who's one of the admins who you work with, we all work with regularly. She says, so proud of you. We're so lucky to have you as a chief resident. And I feel we're so lucky that we're bringing you on as faculty here as well. Other questions? Oh, yes.
Medical school questions. I think you're amazing. And you did a fantastic job, obviously. My question is kind of this idea of, how ready medical students should be as they start their intern year and having to talk about spikes. I went here and we had a big curriculum on spikes. I think part of the didactic even, and we had the same standardized patients that we use in residency. And I don't know if it's just we're, exposed to such amazing programs here already at UW. And when I came to intern year, I thought that was the norm, that everybody should have heard of spikes and had big training on it in medical school. And so I was wondering, were you guys doing any sort of assessment early on to know what the baseline skill level was before anyone started the workshop? And if you're planning on disseminating any of that work to like medical schools so they can improve like medical student readiness to start intern year?
That's a great question, Gabby. I think informally, well, we did, when we surveyed people before the workshop intervention, we did ask them, how confident are you in your skills? And it was about 40 to 50% reported either being somewhat confident or very confident. So I think I get the sense, and then also in talking to folks at the University of Iowa, for example, who's similar to our medical school, I would say, having trained there, is that there are a lot of curriculum out there for medical students. I would say at least half, somewhere between half to 75% of medical students, that's my general sense, and kind of looking at the literature and talking to people, have the spikes framework or some kind of framework for addressing difficult conversations with patients. And that's I get the sense from residents too. We would have them raise their hands at the beginning of each workshop, like, how many of you have heard of spikes? And the majority of people had, which is great, which is awesome. So I think it's becoming more standardized. I would say that I think what seems to be happening in medical school training now is like going even more advanced than that, in terms of how do we layer on trauma-informed care to our physical exam and interviews early on as medical students, like just the really basics, like if you're doing a thyroid exam, like don't sneak up behind your patient or ask permission and that sort of thing. And so I think that's something we can do here even. We don't really talk much with interns about trauma-informed care, for example, some of those higher level things, because we always think, oh, the seniors will do that. But a lot of times then the seniors tell us like, oh, it would have been great to have this earlier. So it's kind of layering on those higher skills earlier. And in terms of disseminating this, I think the goal is to publish this to MedEd portal, I would say. That's kind of my starting point. And then when I go to SGIM, I'll definitely try to talk with folks to see like what they're doing at their institution. Sorry, was that me? Great.
That was an amazing presentation. Thank you. So I would just want to follow up with a comment around one of the exciting things happening in education now is this kind of construct of individualized learning plans or ILPs in going from the UME to GME transition. And I think that's going to be really interesting because of the idea of different interns come in with different strengths, not only as individuals, but also depending on where they went to medical school. So I think some of these things will be very interesting to think about how residency programs address interns coming in with different strengths and universal versus a little more individualized curriculum over time. Be very interesting. My question actually is around this idea of advanced skills versus base skills. And you started to bring that up around trauma-informed care. In thinking about the crucial issues of health disparities in our country, and in the world, actually, what are your thoughts about how to incorporate some of the key aspects around cultural humility with early communication skills?
Great question. Thank you. I think our general goal has been to incorporate those skills earlier for cultural competency and addressing, health disparities in particular. This year, one of our associate program directors, Dr. Andrea Schnell, really was sort of our leader in terms of starting. She could do a whole grand rounds on what she's doing for the interns and seniors in that area. So I think that this year was a great year of growth for our residency program and teaching those skills. And actually, so she had a workshop for the interns and for the seniors, essentially. And actually her idea for next year or this coming academic year is to, rather than wait for the interns to be exposed in the fall, it's becoming a part of our orientation. So including that material even earlier. And I think I also want to acknowledge Kelsey Holbear and Steve Fan, who are third-year residents who developed a workshop for seniors that they implemented for the first time with a grant this year on kind of trauma-informed care and addressing health equity concerns. So I would say that that's focused on the senior resident, but I think that we can continue to think about how to weave those concepts in for the interns. Because several grand rounds have kind of addressed, like even just last week, Dr. Safford brought that up at her, in her Q&A session with residents, and she emphasized how it needs to be a part of almost every lecture. If we're going to talk about AKI, let's talk about disparities in access to adequate healthcare for people with chronic kidney disease who are, in underrepresented minorities. So it's an extra step that I think reaps a lot of benefits, because it reminds us each and every time that this touches every topic. It's not just isolated to a workshop, for senior residents. I move my hands too much.
Thank you, Dr. Floden. Wonderful presentation, more accolades online, more questions here. Please come down and talk to us, Dr. Floden. Thank you.
All right. Thank you.